4 words. That is all it takes for your insurance company to walk away from any claim. A cancer scan, a cardiac procedure, a surgery your specialist ordered, a test your doctor says you need. Without giving you a real medical reason, without having a physician actually review your case, and without breaking a single law, those 4 words are, it's not medically necessary. Right now, UnitedHealthcare, CIGNA, and Aetna use those 4 words to deny hundreds of millions of dollars in legitimate claims every single year. But here is what they are not telling you. There is a specific phrase you can say when you call your insurance company after receiving one of those denials that changes the entire conversation. It is something their representatives are not trained to handle, and it legally forces them to treat your case differently. I'm going to give you that phrase before this video is over. But first, you need to understand what is actually happening when you receive a denial that says those 4 words. Because it is not what you think. In 2023, the American Medical Association surveyed physicians across every specialty in the country. 94% of them said that prior authorization has delayed necessary care for their patients. 94%. That is not a fringe finding. That is essentially every doctor in the country raising their hand. And among those same physicians, 1 in 4 said they had a patient who suffered a serious adverse health event because of a prior authorization delay or denial, not an inconvenience. A serious adverse health event, meaning a patient got worse or was harmed because their treatment was blocked. But here is the number that should concern you most. According to the Kaiser Family Foundation, among patients on Medicare Advantage who received a prior authorization denial and then appealed, 83% won. 83% of people who fought back won. And yet only 1/10 of 1% of patients who receive a denial ever file an appeal. 1/10 of 1%. That gap between 83% success rate and 1/10 of 1% participation rate is not a coincidence. That gap is a business model, and it is built on 4 words. If you have health insurance through your employer, through the marketplace, or through Medicare Advantage, what I am going to show you in this video applies to you. This is not about a rare edge case. This is how claims are being processed for 180 million Americans right now. Stay with me, because in a few minutes, I am going to show you what was inside a federal lawsuit that reveals exactly what it's not medically necessary actually means when it comes out of one of these systems. When your doctor orders a procedure that requires prior authorization, your insurance company is supposed to review it. But here is what most people do not understand. Your insurance company does not use the same definition of medically necessary as your doctor. Your doctor uses clinical judgment, medical training, your specific health history, the current standard of care in their specialty. Your insurance company uses something different. It is called Clinical Criteria Guidelines. These are internal documents the insurance company writes itself. They define what qualifies as medically necessary according to their own policy, not your doctor's opinion, not established medical consensus, not the specifics of your case. Their document, their definition, their decision. And those documents are updated regularly, not based on new medical research, based on cost projections, utilization patterns, and actuarial data. So in practice, here is what happens. Your doctor reviews your case and says, this patient needs an MRI. Their symptoms, their history, and their failure to respond to conservative treatment indicate imaging is the appropriate next step. Your insurance company looks at its internal guidelines and says, our criteria require a patient complete a minimum of 6 weeks of physical therapy before we will approve an MRI. Your doctor met the standard of care, but your doctor did not meet their criteria. And that distinction between medical standard of care and insurer-defined criteria is the gap where it's not medically necessary lives. But here's where it gets significantly worse. Because even that criteria-based review would at least involve a human being reading your file and making a determination. In many cases, that is not what is happening. And when I show you what was inside a federal lawsuit filed against one of the largest insurance companies in the country, you are going to understand why the phrase, it's not medically necessary, has stopped meaning anything at all. Let me tell you about Linda. Linda is 61 years old. She lives in Phoenix, Arizona. For 16 years, she has been covered under the same employer health plan through her husband's company. 16 years of premium payments, not one missed month. Last spring, Linda's spine specialist ordered a lumbar MRI. She had been experiencing severe back pain for 4 months. Her specialist had already tried conservative treatment, 2 separate rounds of physical therapy, anti-inflammatory medication, a cortisone injection. None of it worked. The specialist documented all of this in the prior authorization request he submitted to Linda's insurer, Aetna. Aetna denied it. The letter said 4 words. It's not medically necessary. Linda called Aetna. A representative told her that a clinical reviewer had looked at her case and determined that physical therapy had not been completed for a sufficient duration. Linda told the representative that her doctor had documented 2 full rounds of physical therapy. The representative said the documentation did not meet Aetna's internal criteria. Linda asked to speak with the reviewing physician. She was told that was not possible. Linda paid for the MRI out of pocket, $4,200. Money she put on a credit card. The scan found a herniated disc compressing her spinal cord. Her specialist told her the delay in diagnosis had made surgical intervention significantly more likely. What Linda did not know at the time was that she had the right to request an internal appeal. She had the right to demand in writing the specific clinical criteria Aetna used to deny her claim. She had the right to an independent external review by physicians with no financial relationship with Aetna. And under federal law, she had the right to receive a decision on an expedited appeal within 72 hours, given the urgent nature of her condition. She did not know any of that. She found out 8 months later. Linda's story is not exceptional. It is the median experience. The Kaiser Family Foundation analyzed Medicare Advantage prior authorization data. They found that in 2023, Medicare Advantage plans issued over 35 million prior authorization decisions. And among the small fraction of patients who appealed, 83% won. 8 out of 10 people who fought their denial walked away with coverage. But only 0.1% of denied patients ever filed an appeal. Insurance companies process tens of millions of denials every year. They know what percentage of patients will push back. They have modeled it. They have priced it. And they have built their denial systems around the fact that most people are Linda. Not because she is naive, but because no one told her the process was not over when she got that letter. It was not over for Linda. It is not over for you. But here is where it gets worse. Everything I have described so far is the official version. The process as insurance companies say it works. The reality that came out in federal court is different. In 2022, a class action lawsuit was filed against CIGNA. The lawsuit obtained internal company documents showing that CIGNA had developed a proprietary system called PXDX. Here is what those documents showed. Over a 2-month period, CIGNA physicians used the PXDX system to process and reject over 300,000 prior authorization claims. 300,000 denials in 2 months. The average time a CIGNA physician spent reviewing each claim before issuing that denial, 1.2 seconds. 1.2 seconds. You cannot read a patient's name in 1.2 seconds. You cannot open a file in 1.2 seconds. What was happening was not a medical review. It was an automated match and reject process. A computer compared a billing code to an internal criteria list and flagged it for denial. A physician clicked to confirm. The whole thing took less time than a single breath. And every denial letter that came out of that system said the same thing. It's not medically necessary. The lawsuit was settled. CIGNA denied wrongdoing, but those internal documents are part of the public court record. UnitedHealthcare built a parallel system. It was called NH-Predict, an artificial intelligence algorithm the company used to determine how long patients should receive post-acute care following surgery or hospitalization, skilled nursing facility stays, home health visits, rehabilitation services. A 2023 class action lawsuit alleged that NH-Predict had a documented internal denial rate of 90.4%. Dramatically higher than the rate at which physicians using standard clinical judgment would have denied those same claims, and that UnitedHealthcare used the algorithm's output to override attending physician recommendations. The plaintiffs in that suit included families of patients who died in circumstances they allege were directly connected to care being cut off, based on NH-Predict's determination. On every denial letter, it's not medically necessary. When the determination driving those words is an algorithm trained on cost containment data, not your medical history, not your doctor's recommendation, not the current standard of care in your specialty. It's not medically necessary. It's not a medical conclusion. It is a financial one. The Senate noticed. In 2023 and 2024, the Senate Permanent Subcommittee on Investigations launched a formal investigation into UnitedHealth Group, Humana, and CVS Health, the parent company of Aetna, specifically targeting their Medicare Advantage prior authorization practices. What the committee found was this. All 3 companies had prior authorization denial rates for post-acute care that exceeded the thresholds implied by their own clinical criteria, meaning they were denying claims that by their own internal rules should have been approved. The committee also obtained internal communications showing that company leadership was aware of the direct relationship between denial rates and quarterly profit margins. The more you deny, the less you pay out, the more you keep. That relationship was documented in internal communications at multiple companies simultaneously. The American Medical Association has been tracking the downstream effects of this for years. Their data shows that prior authorization requirements cause treatment abandonment in 30% of cases. Nearly 1 in 3 patients who receive a prior authorization denial does not pursue the treatment at all. Not because they do not need it, because the process of fighting a denial is designed to feel impossible. Multiple phone calls, faxed documentation, 12-page appeal forms, deadlines measured in days. 30% of patients give up. And that 30% represents an enormous amount of money that insurance companies do not have to pay. But here is what that same data shows on the other side. Among patients who do appeal, the American Medical Association found denial reversal rates ranging from 40 to 83% depending on the insurer and the type of claim. Let that sit for a moment. The denial was wrong, documented, reversible, and designed to filter out the people who did not know that. So what does this mean for you? It means that if you have ever received a denial letter with the words, "It's not medically necessary," there is a real and documented possibility that no physician spent more than a few seconds on your case, that an algorithm flagged your claim, that a criteria document written by your insurance company was used to override a medical recommendation. And it means you almost certainly had more road to travel than you were shown. Here is what you can do. Step 1. If you receive a denial that says it's not medically necessary, do not treat it as a final answer. It is not. It is step 1 of a process the insurance company does not want you to know exists. Step 2. Request the clinical criteria in writing. Under ERISA, the federal law that governs employer-sponsored health plans, and under Affordable Care Act regulations that govern Marketplace and Medicare Advantage plans, your insurance company is required to provide you with the specific clinical criteria they used to make their determination. Call your insurer. Say these exact words. "I am requesting the specific clinical criteria and guidelines that were used to determine that my treatment is not medically necessary." Write that sentence down before you call. Read it if you have to. The representative may try to redirect you. Repeat the request. They are legally required to provide it. That criteria document becomes the foundation of your appeal. Step 3. File an internal appeal within 180 days of the denial. For employer-sponsored plans under ERISA, the insurer must issue a written decision within 60 days. For urgent or emergency situations, they must respond within 72 hours. When you file the appeal, ask your doctor to write a letter of medical necessity. That letter needs 3 things. First, your diagnosis with the specific medical code. Second, the treatment recommended, and a clear statement of why alternatives were tried and failed or clinically inappropriate. Third, a statement that the treatment represents the current standard of care in your doctor's specialty. That letter is the single most effective tool for reversing a denial. Step 4. If the internal appeal is denied, you have the right to an independent external review. This is a federal right under the Affordable Care Act for most plan types. An organization completely independent of your insurance company, staffed by physicians in the relevant specialty, reviews the denial from scratch. In 2022, patients who requested external reviews won approximately 60% of the time. This is not a long shot. This is a formal process with a 60% success rate that most people never use. Now, I told you at the beginning of this video that I was going to give you the specific phrase that changes the conversation when you call your insurance company. Here it is. After they confirm your claim is denied, say this: "I would like to know the name and credentials of the reviewing physician who made this determination, and I would like to confirm that physician is board certified in the same specialty as my ordering physician." In many states, and under federal Medicare Advantage regulations, the reviewing physician is required to have relevant specialty expertise when denying a claim in that specialty area. Most representatives are not prepared for that question. The fact that you asked it creates a formal record that you are aware of that requirement. Write it down. Read it if you have to. Use it. If this is the kind of information you want, the specific laws, the documented cases, the exact words and processes your insurance company is counting on you never learning, subscribe to this channel. This is what I cover every single video. Hit subscribe so you do not miss it. Here is the truth about those 4 words. It is 4 words designed to feel like the end of a conversation. It is not a medical opinion. It has not been for a long time. It is a filter built by companies that made a collective $40 billion in profit last year, funded in part by the 30% of patients who received a denial and walked away. UnitedHealthcare built an AI to generate those denials faster. CIGNA built a system to process them in 1.2 seconds. Aetna used them on Linda, and they will keep using them on the people who do not know what comes next. You now know what comes next.